We are live. Hello.
Yeah, can you start? I can't hear you, unfortunately.
Yeah,
Hmm. हेलो। अच्छा, आपका ऑडियो ठीक से नहीं आ रहा है एक्चुअली। ओके। Okay, so I hope you can hear me okay. Okay, so I hope the audio is okay and the video is okay, and I hope that you guys can hear us well. And today I'm going to invite one of my friend and colleague, Dr. Shyama, also to the session today. But before we start and we invite her, um, I'm going to share a case and talk about this case and hopefully have some of your analysis. And then I'll invite her to share about her work. So I hope some of you have got our case. Yeah. So I'm going to talk about a very interesting case of hypertension and anxiety post-COVID. So this person had COVID viral illness, and after that developed a lot of anxiety, panic disorder, and and also has blood pressure now, BP 160 by 100, and this has started especially post-COVID, and he's taking allopathic medicine, but it's not helping. And so the allopathic medicine has been increased by the allopathic physician. So what are the symptoms he has now? Lot of stress. He says, I have a lot of stress and a lot of anxiety and panic. So when someone says this, that I have anxiety and panic, you don't straight away give aconite, like what we normally think about. You have to go deeper. You have to try to understand um, the inner pattern of the anxiety and panic and things like that. So I tried to understand what is the anxiety and panic here. So the anxiety here is that someone in the family speaks to him harshly, roughly. It affects him a lot. About his family, there's a lot of stress. About the work, there's a lot of stress. So I asked him, what is the main feeling in the stress for you? And he says that the main feeling is a lot of guilt. Because when someone says something rudely or harshly, I say something back. And when I say something back, I can say something very, very nasty, something very, very rude as well. And that affects me, that why did I say so bad? Why did I say something so harsh and so bad? The other anxiety for me is separating from my siblings. That affects me a lot. Many things going not very good in the family. All these things affect us. Last few days there have been a lot of family fights, a lot of fights between the family where My wife has been speaking very harshly with the in-laws, and there have been many fights where I also have spoken very harshly, and that's caused a lot of bitterness, lot of bitterness between us, and that's affecting me. And what do I do? Because for me, I want that the entire family should be together, and the family shouldn't separate. That's my strong feeling. So when I understand this situation, I try to understand. Okay, let me understand the his basic nature and temperament. About his basic nature, he describes as someone who's very honest, someone who is very composed, but has very strong moral values and ethics. Doesn't get angry much, but won't speak negative about others. However, when he gets angry, he can speak very loudly in anger, but very sensitive if family members speak to him rudely. He's very sensitive about family members. Lot of fear and dreams of snakes. Also, what is his biggest fear? His biggest fear is that everything in the family, the bond should be good, and that the there shouldn't be any losing of relationship in the family. Especially, he's scared that due to fights in the family, there should be some breakage in the family. What the feeling there in the fear? He says, I feel that very guilty because I tend to say some things because of which there are certain fights in the family. I feel very guilty. I think it's my mistake. If I say something bad, I think I have done something wrong. And I think this is my main tendency where I have a pattern of kind of blaming myself in that way. And then I asked him, can you describe about any other stressful situation? And one of the stressful situation was about handling parents. And especially when parents speak negative about me and my wife to others, that affects me. I feel that my parents and family members are attacking my wife, and I feel all the people are attacking me. I feel like a danger from family members towards me. That's my main fear. I cannot tolerate the idea that people are trying to attack me. There's a strong feeling there. He has a very strong craving for fast food and dal rice. Very thirsty. One of the main things which I saw in the case was that he was very restless. So how do we analyze this case? Let's see some suggestions from some of you guys. What are your guys' suggestions? Some doctors are suggesting certain remedies. Let's see. Any suggestions? Kali Ars, Shrushti. Okay. Any other? Remember, Shrushti, one of the main symptoms of Kali Ars is very chilly. If the patient is not chilly, forget Kali Ars. Any other suggestions? Yeah. So one of the main things, manganum. Manganum. One of the main theme is that of bitter feeling, naja. But you can't see animal qualities here, Ruchi. Vipul, naja, Meenakshi. Okay. So one of the main things we see here is a lot of theme of family, isn't it? A lot of bond, a lot of losing. So this gives you a lot of fourth row of the periodic table, but also there's a lot of guilt, a lot of blaming, isn't it? And lot of restlessness. So here you can see a lot of issues of fourth row of the periodic table. So when we put this in repertory, so let's see what the rubric that we have taken. One of the main rubrics that you can see in this case is constantly blaming oneself and constant feeling that I have done something wrong, and lot of feeling of 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 repentance and a feeling of danger from his family. So when you put this together, you see one of the main remedies coming up as calibromatum. You can see the theme of Cali to do with fourth row of the periodic table, that is the family, the group, the bonding, And bromium, the theme of guilt. So you can see this mainly with the idea of themes. This is a strong feeling of Kali Bromatum that they have done something wrong. So Kali Bromatum 30 I just gave for 2 days, and after that, majorly, uh, the patient has been doing very very well. Just within 3 weeks, all the allopathic medicine was stopped, and his state of mind and his anxiety and everything was much better. Yeah, he did very well. Even after 2 months, we followed up, and he's still doing brilliantly better. So let's talk about Kali Bromatum. Yep. I think it's a good idea at this moment for me to invite my colleague, Dr. Shama, to talk a little bit about case taking that she's going to talk about here right now. How to do case taking. Let's see. Dr. Shama, please share some of your ideas on case taking.
Thank you, Gaurang.
Hello,
Yeah, Yash.
you can share the screen. Your screen visible.
Is my screen visible, Yash?
Your screen visible.
Hello.
Yes, my screen is visible.
Okay. Thank you. Okay, so I really want to thank Gaurang for giving me this opportunity to speak on a platform like this, which I've never done before. So it's my privilege, and I really want to congratulate him for all the feats that he's achieved. We've been very good friends since our college days, and I'm really glad to see the way he's teaching and helping fellow homeopaths. Well, he invited me to speak something on organon. As he knows, is one of my favorite subject, and it's been my favorite subject since my college days. And he told me talk something about the practical aspect of organon, or talk something about which a student or a practitioner will uh, use actually, and not just the philosophical part of it. So I'll just try to take you through that journey and speak something about case taking, and I hope you enjoy my session. So clearly, organon, we never see it as a practical subject. We always see that, okay, it is philosophical, it's boring, or it's theoretical, and there's nothing really to, there's nothing really that interests a student in it until they practice. Then they realize, okay, organon really is important. So it definitely has a practical aspect to it. It definitely has the basis on which that we are going to practice, and if we need to be successful in our practice, we need to understand, or we need to have a very strong hold on our organon. And that is why studying organon, or keeping organon in mind, is essential for a practice to develop. Now, when we study organon textbook, we essentially understand that it's divided into two larger parts, like the theoretical part of the book and the practical part. This theoretical part runs from the first until the 70th aphorism, where Dr. Hahnemann has told us the very basic principles on which homeopathy was founded, or the laws that he found, and all the understanding that we have, that we should have for a successful homeopathic practice. And in the later part of the textbook, from 71 onwards until the last aphorism, I say sixth edition 291, he talks about the application of all these principles that he spoke for 70 aphorisms, and how do we do it. So if you go through the 71st aphorism, it clearly tells you the three steps. How do we identify what is wrong with the patient? How do we treat this patient? And how do we go about the other parameters of manage or the patient management? So when we read that Organon textbook, it clearly goes from classifying the disease, from case taking to the pathology of it and the management of specific diseases. So the practical part of Organon clearly flows in a pattern of a patient management. Like how will you manage a patient? You will understand the disease, you will take the case, you will take the symptomatology, you will understand how the drug was proved. And then when you get some specific cases like a one-sided disease or a mental disease, then what should be your approach in managing such cases? And also then the auxiliary mode or the ancillary mode of treatment that he's mentioned. So the second part of the textbook entirely is practical, and it is practice oriented, and one needs to understand them and remember them very well, because in a normal circumstance we may not always correlate the aphorism, but yeah, when we are stuck, when you have a follow up, when you're stuck in what to do about repeating the medicine or increasing the potency or changing the medicine, you will always go back to your organon and question yourself, okay, what was given in the textbook or what was Kent's directive. So organon will always be present dynamically while you are managing a patient. It may not be as flashy as repertorizing or knowing a materia medica drug, but yeah, it's always there, and it always needs to be very strong so that we can practice it correctly. And we don't even if we are not about to give a desired result, we know we come back to our principles and then we apply it. Now when I talk about case taking, no, it's a very famous saying that a case well taken is half cured. So definitely case taking is a process. It's a skill that every homeopath or every practitioner needs to develop it. And it's not only about learning from one case, but it's gradually going to increase as you're going to take more and more cases of different kinds. You will understand that, oh, you did something wrong in the last case and you need to improvise on that skill. So even when you take a follow up, so when I take say case taking, of course it's about the first case that or the new case that we take, but also in follow up when you're stuck and you don't know what to go, but you need to go back to your case taking. You need to understand where you were wrong, and you need to ask the correct questions in the correct manner at the correct time, and then only you will get symptoms on which you're going to prescribe. So unless and until you have not taken your case properly, your prescription, your management, your results, and your practice, everything is going to get hampered. So because I am associated with CMP, and academically, if I think, okay, case taking is a very simple topic to deal academically for giving answers or vivas or theory, but in practical aspect, case taking is something that we need to consciously be very very much aware about, and we should work on. And why it is so important is that when you take a case well, or when you have taken or you've spoken to the patient well, you've developed a rapport with the patient, and this rapport really takes you forward. Like I will give you an example. When I was working with a doctor for many years, I have, like, I was the only assistant, so I used to take all the cases. There were 2 3 patients when I started my private practice. They needed to come back to me. Okay, they didn't want to go to a more senior doctor. Why? Because when I was with them, they felt the connect, they felt the rapport, and they said that, you know only when you give medicines we feel that our child is better, not the senior doctor. And there was no difference between my medicine or her medicine, but it was just because I could develop that rapport, I could speak to her, and I could connect to her in that way that she would want to come back to me. So case taking is also a process where you are building on a strong bond with your patient, that the patient is always going to come back to you. Even a lot of times when you don't give the desired result, the patient will hold on to you because you have spoken to him, you empathize with the patient, you've heard him. A lot of times we hear that the allopathic physicians would not hear the patient. So only by hearing your patient's problem or just giving them that ear and just being patient with them, it makes them feel very good, and they leave your clinic with a with quite relaxed mind that okay, somebody is bothered to listen to me. So we need to be very conscious about taking the case. We need to be very aware of what we are talking, how we are talking, and when we are talking. uh, so when I say case taking, or when you're sitting in that chair and you're talking to the patient, you clearly have certain purposes in your mind, and you need to be very, very clear about these purposes. And what are these purposes? So you need to know the diagnosis of the patient. You need to come up with a totality, come up with the characteristic symptoms. You need to find the remedy at the end of the day so that you can prescribe. And then you need to understand whether this patient needs some sort of advices or counseling or some auxiliary mode of treatment for uh, for the complete management of the patient. Now, when I say about these purposes, it's not only one purpose that you need to keep in mind. Your mind always works on, or will always think about all the purposes that are there, and at the same time you need to juggle your mind through that. Now, very recently, if I tell you about diagnosis of a disease, very recently I had a patient, and he was a known case of psoriasis, and he came after a long time. And I happened to ask, like, in the history taking, he'd got COVID almost a month back, and he came back with pain in the fingertips and finger joints, and there was slight discoloration on the fingertips. Now, when I was asking, the diagnosis part of the disease for me was still unclear, that what is actually wrong with this patient. Is this pain something related to the joints, or this pain is something related to the blood flow of the patient? And that is what, that was constantly happening. That question was happening in my mind, and even with the differential questions I could not come up with the correct diagnosis. So for that moment, whatever symptoms that I got of the local joints, I just prescribed on that, and I told him to do a Doppler the next day so that I understand whether it's a vascular phenomenon or a joint phenomenon. And to my surprise, the Doppler came back and it was a thrombus. And I had to immediately change my medicine, because what medicine I gave on the symptoms on day one was based on the symptoms that I took, thinking that it could have been a joint complaint. So when my diagnosis is not clear, my understanding of disease, or the understanding of my totality, like the next point of forming totality, is totally dependent on your diagnosis. Like, he gave me a symptom of the pain in the fingertip getting aggravated, hanging the uh, the fingers. Now, if that was a joint complaint, it became characteristic. But if it was a vascular phenomena, it was a common symptom, and I had prescribed on that modality, because for us, if anybody comes with positional relief or amelioration, we'll take that in the totality. But it was completely discarded in the following prescription. So when you're taking the case, you may not be able to diagnose it on the same day when the patient is coming. You may want to wait for certain investigations to come back to you, but you have to always keep in mind that when you get up from the chair, you have at least 2 3 differential diagnoses in your mind, for which you would have suggested something, some investigation, so that you're clear about what your patient is suffering from. Then we talk about finding characteristics. So as I said, if you're not going to be sure of your diagnosis, how do we define characteristics? We will say that characteristics are some symptoms that are away from the pathology. But if we are not sure about the pathology, we are never going to be sure about what is characteristic and what is common in that patient. So when we are sure about our diagnosis, we somewhere are also telling ourselves what is more characteristic, what is the symptom that I want to prescribe on, and what is something that I would want to let go of from my totality. Now, when I say about characteristic, when you're taking the case, because you have to figure out the characteristics, a lot of times the patient may just tell you, if it's an acute case, they may just come up with the symptoms. But in a chronic case, to find characteristic is again a skill. Okay, so if I have to find characteristics at physical level, I need to make patient aware of the possibilities, or rather I need to make patient be aware of himself or herself. A lot of times when you ask patient that you know what is the pain like, for most of the patients are just They are just blank, that they don't, because they have not been with themselves. They have not seen it from that perspective, that pain can be pricking, it can be burning, it can be splinter, so those possibilities are there for a homeopath, but we need to put it across for our patients, so that they can tell us what are they actually experiencing in that situation. So always, whenever you are taking a case, you try to understand what is the experience of that patient in that process or in that situation, whether it is pain or whether it is anything else that you're talking about. So if I want to give you an example for that, we were seeing a case of female infertility, and she was a known case of PCOD, and she had amenorrhea for a long, like almost I think 8-10 months. And when I was taking the case, and while taking the case, because we have to go into the intricacies, we have to figure out the characteristic. I asked her what are her symptoms before menses, so are there any changes. So you know uh, a lot of times females will be prejudiced that okay, before menses I may get abdo pain, or I may get leg pain, or with the common symptoms premenstrually that a female will get. So you have to make the patient aware that anything that changes, whether it's your sleep pattern, whether it's your appetite, whether you get any other symptoms. So because the patient is not a homeopathic physician, the purview for them is very smaller. You need to increase that purview, and you need to bring them to that level that okay, they can be with themselves and think if there was something that changed before menses. And she typically told us a symptom of increased sexual desire before menses. So this became one of the major prescribing points for us when we repeat. Of course, there were other symptoms, but if I wouldn't have gone into that detail of asking, because they would never tell you the sexual desire part so easily, and also they will never correlate it. So for us to even find the characteristic, first we need to be aware of what are the possibilities of finding, where all can we find, what all can we ask, so that we find a characteristic. So it's very important for us to emphasize on the modalities, on the concomitants, because for a normal man, their disease ends at sensations. Okay, they will just tell you I get pain, or I'm getting numbness, or I'm getting tingling, or I'm getting acidity. For them it just ends there, but for us the modality and the concomitant part is extremely important for prescribing. Also, if I tell you about mental characteristic, very interestingly, what I've seen in case taking initial days, all of us are very very eager to label somebody, like this person is anxious, or this person is fastidious, or this person is sad. So when you put the patient into that category, you become prejudiced. Okay, so when you're taking a characteristic at the mental level, or you want to know the mind of the patient, you would you can never go about asking somebody if you are anxious. Do you get anxious, or are you sensitive? No, you rather put them in a situation, you give them a situation, and then you figure out that what is their experience in that situation, or what is it that they how is it that they react if there was any incidents in their past. So starting of the mental, or the mental section of the case taking, it's very important to give them that freedom, or give them that openness to answer or to experience, rather than putting them into certain fixed questionnaire that you would have in your mind. Now, again, of course, we need to understand what is the emotional state of the patient, what is the intellectual state of the patient. As a physician, we need to figure that out, that is correct. But how we figure it out, and some things are very obvious, or some things are very observational. So in such instances, you will never ask them about their sensitivity or their anxiety. If you're seeing somebody who's physically restless while you're case taking, or who's constantly seeing the watch, or who's doing some particular habits, you understand that okay, this may fit into some certain kind of a person. So you may not even directly ask them that question. So when you are searching for characteristics while taking a case, you make sure that you don't put the patient into a very small space where they have just to say yes or no, or they are just they are also themselves feeling that you will judge them. Like a lot of times we see fastidiousness. No, nobody's going, like if you are going to take fastidious from your question, that if you like cleanliness or no, then nobody on this earth is going to tell you, okay, I don't like cleanliness, right? So finding out fastidiousness or finding out that desire for order or cleanliness needs to come up from a very different angle, and not from your question of asking whether you like cleanliness or not. Then it comes to finding the indicator. Now when you are taking the case, your entire purpose is that you have to prescribe to this patient. So if you have taken a case and you're clueless about the remedy at all, then you need to go back to thinking what wrong you did in your case taking. uh, when you get up from that seat, you need to at least have 2 3 differential remedies in your mind, and that will come only when you have taken the case from that intent of figuring out a remedy, or figuring out uh, what is it that I want to prescribe, or which is the medicine that will be best suited to this patient. And in that, in finding that indicated remedy, a lot of times towards the end of case taking, what we ask is called the confirmatory questions for a particular remedy. Now I know according to rules we are not supposed to ask direct or leading questions as per our guidelines. But yes, towards the end of the case, if we are confused between two very similar looking medicines, then we need to ask a confirmatory question for a certain remedy, so that we are more sure about it. So when you're taking the case, and if you come down to a diagnosis, you come down to 2 3 differential remedies, then it is your job to figure out from your confirmatory questions, and how do you build up those confirmatory questions in your case taking. Unless and until you know your remedy, you're not going to be able to do that. So like for again, I'll give you that example of the patient who'd come up with thrombus post COVID. So for him, so when I figured out that it was a thrombus occluding the vein and decreasing the arterial flow, again I reshuffled my entire repertoire, like the entire totality change, and then I came up with 2 remedies. It was arsenic and sickle core. And to find the indicated remedy, I had to ask a direct question of the modality, which what temperature suits them. And on that basis, because he was better with heat, I gave him arsenic, and he completely improved from his state of thrombosis. So my point being that also in your case taking, it is your duty to, if you are confused between 2 3 remedies, then to understand the confirmatory question of each remedy and ask it accordingly, so that you come down to a final diagnosis of the remedy, or the final indicated remedy. Then when I talk about counseling and auxiliary mode of treatment, so in your case taking, a lot of times we need to advise the patient, whether it is at emotional, whether it's in the form of uh, guiding them to do something, or it's some other mode of treatment or therapy, or some diet or some regimen that we need to change. And all that will be based on how well you have understood the lifestyle of the patient, or the daily routine of the person. And from that, a lot of times you can just do some minor changes, and a lot of diseases may just settle down by, like, most commonly if the patient is suffering from hyperacidity or constipation, and your certain small home remedies or certain changes in their diet or regimen will improvise their symptoms. You don't even need to give any medicine. But these things you will understand only when you understand what the patient was doing wrong. And knowing what he's doing wrong will only come up when you ask them what has been their daily routine. If you don't understand their daily routine or their habits in your case taking, then somewhere you will not be able to correctly guide them about what auxiliary mode to give, or what counseling this patient will need. So again, when you're taking the case, you make sure that you are not only asking, or you're not just concerned about the symptoms, the LSMC part of the case, but you're also connecting with him about his routine, about his diet, about the food that he eats. Because a lot of times most of the diseases can be slightly better. They may not get cured, but yeah, they can be managed with changes in the diet and the regimen that we give the patient. Now, for these purposes to be solved, There's certain prerequisites. Now again, these prerequisites are going to be very correlated to the purposes that we are going to have in our mind. For example, knowledge of medicine. Now, when you are sitting to take a case, I'm sure you know or you understand the importance of knowing your medicine part of it, and that is for diagnosing the patient. And if you somewhere have a flaw in that, or somewhere you can't understand what disease you are treating, then again everything goes haywire. Your characteristics are haywire, your indicated remedies haywire. We don't know, we are kind of lost. Like I had a patient who was hypothyroid, and when I so I would specifically want to say that when you're taking a case of a hormonal imbalance, like this case of hypothyroid that I was talking about, and when I asked him about his thermals, he was chilly. Now at that time I need to remember that if I'm say taking a hypothyroid case, I'm not to take chili as my indicate as one of my symptoms for my totality, because hypothyroidism will make or can make a patient thermally chilly. So if I'm taking a or if I'm sitting with a case which I know is a diagnosed case of hypothyroidism, then all the symptoms of hypothyroidism in my medicine should just strike me that they are going to be present and they are going to be common, unless and until they are with very high intensity. So when while dealing with such patients, we are not going to take give importance or get into the zone of their diagnostic symptoms. So unless and until your medicine is strong, or unless and until you know the diseases well, you will not be able to differentiate between what is common and what is characteristic, even while taking the case. For example, if I know that, I would have assumed that chili is what I wanted to prescribe certain remedy, then I wouldn't have gone further, or I would have just, taken that as one of my prescriptive point and maybe given a wrong remedy. So you need to be very sure of what disease you are treating, so as to understand what symptom you will take in your totality. And then your knowledge of materia medica and repertory comes into picture. Now I have seen a lot of seniors or a lot of good homeopaths using even repertory while they are taking the case. Now why is that so? Because you can't you can't remember, or you can't at a student level you would not know all the possibilities of modalities of concomitants or of sensations that one patient can have, or a pain can show us. So like I had a case of eczema. Now atopic eczema, which was little resistant, and I couldn't understand why she's not responding. And then I just happened to ask about the diet, and if there is some maintaining cause. And then I got to know that she was having biscuits daily, the not creamy ones, the normal ones, but she would have it daily. And then I asked her that, why is that? She's like, no, she really wants biscuits every day. Like she cannot, there's not a day where she will not eat biscuits. Now I don't know if it was the maintaining cause, or it was it was just present. But yeah, then this desire for biscuits came up as my prescriptive point, and then when I prescribed on this, her itching or her eczema was better. So this desire for biscuits, I would have never asked. Like even if you are asking craving and aversions, again to tell you, I am not very fond of cravings and aversions as such, because when we ask them, we are so prejudiced, or we make them into we put them in such a spot that I don't know if they are genuinely something that we should prescribe on. Like if you are आपको मीठा अच्छा लगता है, आपको तीखा अच्छा लगता है. So it's very ambiguous according to me. But yeah, even if you want to know the cravings and aversions, there's a way to ask. So you need to either ask them their diet, their regular diet was what is it that they really want every day, or what taste it is that they would want or they would prefer. Or the best section or the best application of cravings and aversions comes in when you're taking an acute case, where you understand or you ask them whether this in this acute phenomena, is your has your craving or aversion changed in any way? Is it something that you desire? something that you don't want at all. And at that time, whatever craving and aversion you get, that really ranks higher in your totality. So when you know your materia medica, and when you know your repertory, you can be, aware of a lot of possibilities of such smaller symptoms, which we may not see largely when we are talking about a medicine. But yeah, when you study repertory in that depth, you understand, okay, this symptom or this sub rubric, or this instance is also possible. So let me just ask, let me just understand that whether this so my questionnaire one will direct me to diagnose a case. The other section of my questionnaire will direct me to diagnose the remedy that I want to give. So, for example, joint pains, so you will understand whether it is rheumatoid, whether it is osteoarthritis, whether it is autoimmune. You will understand that from your knowledge of medicine, and you will ask questions based on that to differentiate. But when it comes to prescribing, you will ask the same person all the modalities and all the concomitants to understand where in repertory and materia medica do they fit, or what remedy comes up from there. And then when we talk about the general guidelines, like you have to be unprejudiced, or you have to be attentive, or you have to be specific. So wo to, like, that is always going to be there. You can't sit with there with a lot of prejudice. Like, a lot of times it happens, at least with me, that I think there is a section in organa also given about favorite remedies. Sometimes you're just so prejudiced, or some remedies have worked so well for you that you start seeing patient in that remedy. You will try to fit the patient into that remedy, and it will forget the remedy, also about the symptoms or the rubrics also. So in initial days, if you've seen some nice rubrics, you will try to fit the patient into that rubric. You will try to ask the question leading them toward that particular rubric or medicine. But that consciously we need to remember that we don't have to we don't have to have that kind of judgment already about either what remedy will work, or what kind of patient are we dealing with, or what disease we've dealt with. So in all the three aspects, we don't have to be very prejudiced about going, about managing the case. And then comes your skill of observation, which is always going to be there. Like, I remember when I was working with this doctor, and one patient was waiting outside in the waiting area, and he was really rash with the compounder, and he was arguing for his chance, and all that. And the moment he enters the doctor's cabin, and all his demeanor changes completely, and he's sophisticated, he's talking well. So of course we will take the case for like, we will know the details, but somewhere you have already taken a symptom into your account, or you've already seen the behavior of the patient, and you have inferred that this person may fit into some kind of some symptomatology like this, or a remedy like this, whose behavior is like this. So this skill, like, as they say, the case taking will begin in the waiting area itself. So uh, uh, the senior I used to work with, she would purposely make certain people wait for a while, so that she could see what kind of behavior they show when they are outside, when they are with people whom they don't know, when they are with people, when they are with compounders. So they will understand their change of behavior with people. So that is one. So observation is something that, of course, will develop with time. You can't expect to observe everything on the day one when you enter the OPD. But yeah, you have to be conscious that you have to improve your observation skills. You need to work on that. You need to not only hear the patient, what the patient is saying, but also see what the patient is doing. Like, we had a patient, she was screaming, like she was just screaming with pain, and she was just like, she made us also mad with her expression of the intensity of pain. And when she was complaining of knee pain, and when we asked her to go to the clinical the bedside, she just stood up fast, and she just walked, and she climbed in a way where she pressed her knee, and there was nothing. Okay, there was nothing. And when we were examining her, she just sprang when we touched the knee. And when we diverted her, when we spoke to her about something else while examining, there was no tenderness. So if we had just gone by her intensity, and if I would have given marks to the pain, I would have really been lost in my prescribing. So you need to observe what is the intensity that the patient is saying, but what is the intensity the patient is even portraying. So examination, while you are examining also, it's, you are taking case in certain way where you are seeing whether whatever he's being told, is it matching clinically. So if we would not have done that, we couldn't have understood that whether this patient is hypochondriacal, or exaggerating her symptoms, or what is the state basically. So I'm not going to go into the interpretation, but I'm just giving you instances where you can observe. So a lot of times I had heard that people will keep their examination bed also little far, so that they want to see how the patient walks there and goes. They want to see the gait, they want to see the speed, they want to understand the behavior even in that second. And that will change the prescription, that will change the way that they are, their disposition is. So yeah, so these are the purposes and the prerequisites that one should have while taking the case. And hence we say that it's a multidimensional process where the physician has to work on various aspects of the patient management simultaneously. Like, you're diagnosing, you're thinking about the remedy, you're thinking about the repertory, you're thinking about the auxiliary mode of the treatment, you want to know the characteristic symptoms, you want to understand the diet. So there are so many things that you're constantly working on when you are taking a case, that if even if you miss out on any of that thing, there will be a major effect on the management of the patient. Okay, so you need to correlate all the prerequisites with the purposes of case taking for a successful prescription. And what do you need to remember? Okay, now this is something from my side. So you need to remember that it's a conversation and it's not an interrogation. When I say not an interrogation, means of course we are not filling some forms, or we're not giving them yes, no, take, right. So not like that. So you converse with the patient. In that conversation, you need to make sure that all your prerequisites are present with you and all the purposes are met while you are prescribing the patient. So you don't need to make them feel that okay, gussa aata hai ki nahi, rona aata hai ki nahi. You don't have to do that. You need to be very very conversant with the patient to get the most of it, because until and unless the patient is expressive with you, you're not going to be able to prescribe anything to the patient. It needs to be modified depending on the type of case, the patient, and the circumstances. So this is one point that I really want to emphasize on. Like, when we were in OPD, we also, when I see students now in OPD, we are so used to taking cases for 45 minutes, 1 hour, 1 hour 15 minutes, that we have a lot of leisure when we are as a student. But the moment we go into practice, the moment you are starting your own practice, you are so lost, because sometimes you have to prescribe in half an hour. You have to take the case, you have to repertorize, you have to make the medicine, you have to explain the medicine. You may not, like, if you're practicing in a polyclinic and if you have a 2 hour slot, and if you have like 3 new cases, you can't be spending 1 hour on each patient, right? So uh, this case taking skill needs to be modified as per what type of case you're seeing, what kind of patient you are seeing, and what are your circumstances. How much time do you have for a case to be taken and to be prescribed on? And if you fail to modify yourself, then you will not be able to either you will lose on patients, or you will not understand what characteristics have you. You'll just prescribe on the common symptoms that you're getting. So you need to practice yourself, that if I have 10 minutes, how am I going to? So I remember very clearly when we were doing our MD, there was a patient admitted in the IPD, and she was an asthmatic, and she was severely in that spasm. And while she was being admitted, so we, like, it was this all rush happening to admit her and all. And while she was being admitted, the only thing that she did, that she cleaned her bed continuously. She was restless and she was just cleaning her bed. She was making her bed properly, her bed sheets proper, pillow proper, and that was it. That was the only thing that we saw of the case. And then we examined. Of course, the preliminary data and all was already taken because of the admission, and that was the only behavior on which we prescribed the patient. And at that time, if we would have sat there and we would have asked, okay, what is your past history, what is your gynec history, and what is your craving and aversion, the patient either would not have told us, and like would have been irritated and not told us anything, or would have been surprised and not told us anything. What is wrong with this doctor? I can't even speak. So in such instances, what you need to do is just observe the patient in that acute state. You give the medicine that is indicated in that acute state, and you come back the next day for a constitutional medicine. There's no rush. But if we don't modify ourselves while taking the case, we are not going to improvise on ourselves as physicians. Like a lot of if you see the more established homeopaths, they just see the patient for 5-10 minutes. That enter came in the whole case is taken by the intern. But sometimes their observations far more sharper than even if the after the intern has spent 1 hour with the patient. So the point is that it's not about the amount of time you're spending, but it's in that time how aware you are of what is happening to this patient, or how is he or she behaving, and that is more important. Again, it should aim to fulfill all the purposes of case taking. You should try and figure out the diagnosis, the remedy, the auxiliary mode of treatment as far as possible. A lot of times it may not be on the first go, but yeah, you should always try to tell yourself that okay, I will get, today I will take this case in a manner that I know everything about, everything, like all the purposes that I need to fulfill for a patient. So yeah, that should be your aim for every case that you're taking. And if that is not the aim, it's very incomplete that you go, because again, in your private practice you may not get a lot of time to repertorize again, and to think about the posology for 10 minutes and susceptibility. Everything is going on simultaneously while you're taking the case. While you get your LSMC, you are already thinking about what is the susceptibility of this patient, or what could be the potency that this patient could get, only based on the physical particulars of the patient. So it's not about, once I end my mind section, I will again go back and think about this. No, when you're practicing, you're going to think about the susceptibility, the myism, the posology, all at the same time. And if we don't practice it at a student level, suddenly when you get it one day after internship, it is going to be tough. So for every student, even in my OPD, I used to insist that just assume this patient is your patient in a clinic, and you how are you going to manage a patient in your clinic? You just try to manage it right now in the OPD, so that you're trained, your senses are trained to see, hear, perceive, understand everything, and all the aspects at the same time. And lastly, we should use the guidelines given in a smarter manner. Like very commonly, we have this habit of starting it from the chief complaint, going to the associated, and then so a case may just begin from any point of the entire case history. We need to be you need to let it flow. If you let it flow, I'm sure you will get more symptoms than you just being rigid that okay, no, I want to now find physical general. And sometimes in while taking the case, they may just tell you a lot of part of their disposition, or a lot of part of their mental state. And if you're still stuck on your no, I'm writing LSMC and I'm figuring out physical journals, and I pay no heed to the mind, or I pay no heed to the change of appetite that this patient has told me, then you've lost the track of it. So you may get any information at any moment in the entire case. You need to be prepared for that, and you need to prepare your questionnaire accordingly. Like if the patient is not sharing a lot with me, what are the things that I will ask, or how will I eventually find out some symptoms that I can prescribe on? Or if the patient is talking too much, how am I going to make him come back to the topic, or make him concise his information? So all these things, of course, will come as you take more and more cases. But yeah, you should be constantly working on that, or consciously working on that. And lastly, I hope you have great conversation with your patients, and you improvise on your case taking skills. You work on that, and hence you get amazing results with homeopathy. So thank you for being a patient listener. Thank you.
Thank you, ma'am. It was really
Yeah.
amazing learning. Uh, Anybody wants to ask questions, then they can ask questions to him. Anybody wants to ask questions, then they can ask questions regarding case taking, homeopathy. Hello. Shama ma'am?
Yeah, yes, tell me.
Okay. So one question is there.
Yeah.
In case the first question is, if we are unaware of language, patient speak, what to do?
Sorry, what's the question?
If we are unaware of language, patient speak, what to do?
Okay. So I think in that case, if you find somebody who can understand a common language, then of course that is better. But if you still can't, then sign language and clinical signs, like if when you examine the patient, or when you understand which system is involved, maybe somewhat you can come to prescribing or figuring out the clinical signs or the objective signs, that objective symptoms that we talk about, like the behavior of the patient that we observe, or when we examine him or her, what are the changes that we see. So that can be one of the routes of prescribing, or that can be one of the entry points of prescribing for such patients. And then meanwhile you figure out, if you can find somebody who can speak a language that either both of you understand, or somebody can translate for you. So yeah, language barrier is there for a lot of people, but in such cases you will give more importance to the subjective symptoms or the signs, to the objective symptoms or the signs that we see. So you will look out for that.
So next question is, in case taking, how much is the
Hmm.
clinical importance?
How much is the clinical
Importance. Clinical importance.
clinical examination of clinical examination ka importance you're asking?
Maybe he's asking that.
Yeah, so I think, as I said, even at bedside you can figure out a lot of things about the patient. And like I gave the example of that lady who was, when diverted while examination, she did not express any pain, so we understand that she's definitely exaggerating her complaints than the actual pathology. There was no tenderness, or there was no edema, effusion. So clinical examination may not always be a part of case taking, but yeah, if you're not sure about certain things, you can, when you're at the bedside, when you're examining the patient, you can confirm a lot of things, or you can ask a lot of things, which because in clinical examination a patient is in a different zone. They're getting examined, they are, they are not in that zone of just being prepared and answering. So a lot of times, you confirm small little things when you are examining the patient, which you found difficult to confirm when you're talking with them. So definitely clinical examination will always help you confirm your remedy, your symptoms, your rubrics, everything, if you want.
Second question is, kindly tell how to make mental symptoms clearly. For example, patients are mostly anxious when come at clinic. Would we take
So
anxiety
yeah,
rubric for
So that's what I said, that for understanding the symptoms pertaining to mind, we need to first understand whether they are symptoms as such, or they are attributes. Okay, attributes are something that the patient, it's like the patient's nature. So not everything about patient's nature is going to hamper the patient, or it should be taken into the totality. So if you are seeing the anxiety of the patient, you will take anxiety. But if you're not seeing the anxiety of the patient, and if you ask that, if do you get anxious in certain situations, then, and if he or she says yes, I don't think it's as characteristic. तो आपको, you need to put the patient in a situation, and then if that expression or that emotion keeps on repeating every time, like whether they're giving an exam they are anxious, if they're talking to somebody they are anxious, if they're alone they are anxious, then yes, you will take anxiety. But if you're just asking, so you should never ask an emotion, or you should never ask, use that word. A lot of times students, they make that mistake, that they will ask that, are you sensitive, do you feel hurt easily, do you cry, very common mistakes. But I think when you derive something from such a question, it may not be characteristic. So we need to find out why this patient is ill, and if his being ill and his weeping has no relation, it's of no use to us. It's just an attribute. So you need to very clearly also prepare yourself and put the patient in a situation where they are expressing. The most easy way to enter into asking the mind is just ask them their daily routine, or about their family, or about what work they do, or if they're ill, how their behavior changes, or how they are perceived with people. So these are various questions that you can begin with, but never ever begin with the emotion that you are trying to figure out. Never ask them that, are you anxious? If you're seeing them anxious, they're anxious, you take it. If you're not seeing them anxious, asking them you're anxious, you're confusing the patient. So you'd never do that.
Kindly tell about the introvert type of patients, how to deal with them, and mostly loquacious patient can give us wrong info by their abnormal talks, how to deal it.
So one about introvert. Now, as homeopathic students and physicians, we are very prejudiced beforehand already, that we need to prescribe on some mentals. Okay, so first and foremost, when you're sitting there, when you're taking a case, you just don't give more importance to mentals and lesser importance. So in your head, all symptoms are equally important if they are characteristic. When you start your case with that, then an introvert patient hai ya zyada bol raha hai, it will not matter to you, because if the patient is introvert, you will have other entry points in the case, and you don't need to pressurize the patient to tell you everything on your first day of meeting. If you put yourself in the position of the patient, and you say, if कल उठ के आपको कोई, somebody is asking you so many questions, you may not be able, you may not be ready to answer. Even if I'm extroverted, I may not answer it to you. It's my choice. But you will perceive me as an introverted person. So we as physicians need to be open minded, that we may not know about the patient on day one, we are not going to label them as introverted, and we can also prescribe on other symptoms beside the mental characteristics, rather than prescribing on a wrong mental characteristic, which is very very important. If the patient is loquacious, and if he or she is diverting, you need to be stern and get them back into the zone, however many times that you have to. But yeah, you need to understand that you have taken that loquacity, you have understood that that is a characteristic symptom, and then you come back to that topic. You consciously make that effort so that the patient realizes that he or she needs to talk on a particular thing.
So one question I'm asking on behalf of students, which books
On behalf of
of students? No one has asked. I'm myself asking because
okay. Okay.
many times students ask which books to refer for understanding case taking, understanding organon.
Okay.
Which
Which
books are
books?
very important? Books are very important for students to refer, especially for first year, second year, third year, fourth year, at different levels. Which books we should read at different levels of our adults. we
So
don't do
honestly,
that.
today for this session also, I've just read Organon 6th edition. So for me, that is the most important book that you need to read, you need to understand, you need to put your heart into. But particularly for case taking, I think Pierre Schmidt has a nice booklet of case taking, which is good. It's a good read. You understand it well. Some cases from lesser writings, when you read lesser writing by Kent and Hahnemann, when you read, you understand what kind of symptoms can you get or how do you go about that. But I think case taking is one skill that is uh, more of observational. When I see somebody taking a case in a particular manner and observe something, and then when I do it, so if I take more cases, I am in a way learning better. So more than any books, like the books are going to give you guideline, but what kind of patient you are going to get and what you have to do at that moment is just your pure skill, your pure understanding when you do it. So I would always tell students that try to take more cases. Like people, interns just refrain from taking new cases. I think there was a point in my like when I was an assistant, there was a day where I had to take almost 8 to 10 new cases in 6 hours. And these were chronic cases of infertility and substantial cases, not acute cases where I can get done in like 15 minutes. So because we had trained in that rigorously, that we understand that now, how if I have 30 minutes for even for a chronic case, I know that what I have to ask, where all I have to ask, what is my prescriptive understanding. So more than books, of course, you can read these books, but if you put yourself into that position of taking a case and observing, it's always a better way of learning.
Thank you. Anyone other else want to ask a question? Mm. So I'm very pleased to announce that soon in February, Dr. Gaurang Gaikwad sir's book is coming on art of repertorization, rediscovering old and forgotten repertories. So it's a very gem book going to launch soon. So stay updated and thank you. Thank you everyone for participating, and thank you Shama ma'am. The lecture was very
Thank you,
informative.
Yash, and thanks to Gaurang, and I wish him a very good luck for his upcoming book. I'm really
So
excited.
we all learn to.
Yeah,
Thank you.
thank you so much. Thank you everybody for
Bye.
being a patient audience. Thank you so much.
Bye. Bye.
Yeah, bye. Good night.